Good morning, everyone.
Good morning.
You don't want to be looking at the top of my head, do you?
Good morning, everybody. I'll just wait for another few seconds to see if any more join, but thank you very much, everybody, for joining. Right, I'll get started then. Thank you very much, everybody, for being here today, and for Sian Thomas, who's going to be presenting. My name is Victoria Binks, and I'm the Assistant Director for the regional team, and I look after people within the North Eastern Yorkshire region for NHS Confed. However, I also lead on a programme of work that focuses on supporting our members around provider collaboration, and this is provider collaboration at any level, from neighbourhood and place through to systems. And as I've said, I'm really pleased to welcome Sian Thomas here. She's the Deputy Chief Operating Officer at the Royal Wolverhampton NHS Trust. And she's going to talk today about how they've developed a vertical integration model, which is with acute, community and primary care services. So as an early innovator, there was no roadmap for how to do this, and they've had to learn as they've gone along. And Sian will talk about the context and history of the model, how it works in practice, and reflect on what's happened over the last 5 to 6 years. So the session will last for about an hour or so. We've got an hour and 15 minutes in the diary. It just depends how much conversation people want to have. So it's going to start with a presentation from Sian in just a moment, and then it will be followed by Q&A. And it'd be really good if, as part of the conversation, people can come off on camera, and sort of take part in that discussion. We've found that it really helps make it a little bit more interactive. Of course, also you can post your questions in the chat as we go along, and I'll be monitoring those over the course of the session, and then Sian can answer those after she's done her presentation. So I'll hand over to Sian now, and thank you very much for coming and joining us today.
Thank you. Morning, everybody. Lovely to be with you. Slightly distractingly, I can see that the auto text is misspelling my name as Sian, but I'm sure that will be fine. It's really important to say as well, it's not just me here presenting today. I'm joined by my colleague, Dr. Sidhu. Mona, would you like to introduce yourself?
Sure, thank you. Hi, I'm Mona Sidhu. I'm one of the GPs and one of the founders for Vertical Integration. And I'll be joining you and speaking to you during this presentation.
Great, so we're going to share the slides between us, so you've got both the operational and the clinical view, and we hope it's very much a true reflection of what we're proud of, where we've made mistakes and what we've learned, and plenty of time at the end for Q&A. So just to start, to give you a bit of context of who we are and our scale. So as a primary care network, we have 8 practices with just over 50,000 as a registered population. Wolverhampton generally is an outlier nationally in terms of its deprivation and ethnic diversity, and our practices largely mirror that. So we have a younger population at the higher end of deprivation nationally, and with a higher ethnic diversity. However, as you'll see from the map, we have got a spread across the city. So actually we do have a slightly more affluent and elder population in the west, becoming more like the standard described population into the centre. As with many primary care groupings, we have a range of estates from 1970s health centres through to former houses that have been converted through to some more modern facilities. As a trust, it's integrated across acute, community and primary care. And I think it's really important to note the community integration, I think, is really important. Sometimes when people talk about the vertical integration, they're thinking primary care to acute, but the community services are absolutely a bedrock of the integration piece. The trust has got a very good reputation. It's CQC good, it's financially stable. The leadership is very long standing. I think our chief exec is the longest serving chief exec in the country. And we've also recently integrated with Walsall Healthcare. So our chair and chief exec are now joint across the two in a group model. So I'll hand over to Mona.
Hi, just to start off with the journey of our vertical integration. So in 2015, we had the long-term plan and come out, and we had lots of people looking at different models of primary care. Some were going for PACS models, some were going for the MCP and care homes model. And at that stage, we thought, what do we want to do? We have a long-standing relationship with the trust. Most of the GPs over here have done some form of training in the trust. I have been a GP at the GIPSy with special interest in diabetes at the trust for several years. So we thought we want to try something different. And the practices who joined vertical integration were actually good practices. And I'm not saying there are bad practices, but they're good practices in that they weren't struggling to recruit or anything like that. They had good CQC ratings. Most of them were training practices and so forth. So at that stage, we started having conversations with the trust. We approached them rather than they approach us to say, we want to do something different. We want to see how we can influence the integrated pathways of working between primary, secondary, and community care. We were talking to them about how to make this possible for almost a year until we went live in June 2016 with 3 practices. Up to now, we're about 10 practices now, and then back to 8. One of the practices when we joined was in a different PCN in locality, not just PCN, sorry, CCG localities, which was made things harder when PCNs were formed and for the network contracts. So that's why they had to leave. We continue to develop the service. And when we looked at the pathways of how we wanted to do it, the novel GMS subcontracting approach was the one that we felt was best. We had independent legal advisors, GPs, and from the trust as well. All the GPs became, and all the staff became salaried employees of the trust. And as a result, we were following very much a consultant model and had access to other with DNC, the Joint Committee for the consultants, and also the Clinical Excellence Awards and pathways and so forth. We still remain quite active members of the CCGs and the ICS. My colleague's actually a member of the CCG board. So we've maintained our relationships with the CCG, with the local PCNs, and with the trust, along with the community services. And just to add also that we very early on got public health involved in our integrated processes as well. Over to you, Sian.
Thanks, Mona. So we think there are lots of benefits to the model. So just to talk you through a few of them. Through the practices coming together as a larger group, because this piece of work did predate PCNs, and then joining with the trust, there is improved resilience in terms of staffing, in terms of corporate support. It has been easier to set up a whole host of joint services. We aren't arguing about money transfer or contracts, because to a certain extent it's all the same budget. And so that's been really helpful in allowing us to try something, fail safely, fail quickly, give it another go and iterate, and then move to successful models really quickly. So just a few examples of what we've set up. We've got joint sexual health clinics with our sexual health service. We've got a home visiting service supported by our community nursing and district nursing team. We have a enhanced care home support team who will be talking to you a little bit more about later. We've got joint clinics with physiotherapy on joint injections, and all of those have been able to happen at pace and in quite a responsive way to emerging patient need. Mona? Have I lost you, Mona?
I think you're still on mute, Mona.
Sorry, I knew there was one person who was going to do it, and I knew it was going to be me. Sorry, I was just going to say, very early on, the trust recognized that we needed to involve primary care in leadership at all levels in primary care trust. So we formed a divisional structure, a division 3. Normally we have a surgical division or a medical division. A division 3, which incorporated primary care, community care, and all other departments which did not have out inpatient basis, apart from pediatrics, were in our division. And we worked really, really closely together. There was primary care representation on all the trust committees and also at trust management level. And every decision that was made at that point, we ensured that it had primary care input and how things could be improved, be it how cancer is being managed and what is the impact in secondary care, pressures on A&E, infection control processes, and so forth. So we really had a truly integrated working with primary, community, and secondary care. Most of the trust consultants and management team have said, do not underestimate the impact you've had over the last few years, because what has really helped us build trust between the organizations and understand the community and secondary care do have a better understanding of primary care than they would have ever had if we sat outside the organization. And I think that's been said by all departments that we worked with. We managed to do things at pace, as Sian's mentioned, because of those connections that we had.
So some of the things that we've done to assist on the resilience piece, it probably won't surprise you. We've centralised the admin and the corporate management. So all of the practices are supported by the trust-wide corporate support services. So HR, finance, procurement, and IT. That gives the resilience. It also means that the practices are fully compliant with the standards that apply to acute and community services. And that adds in an additional level of rigour. But it also means it's freed up clinicians' times. So whereas previously contract holders were also having to look at how they ran the business, they now don't have to become involved so much in those processes. So releasing time to care and letting the experts in things like procurement and finance take the lead in their areas.
In addition, we've also, because of the being employees of the trust, as I said, we've been able to access professional opportunities, leadership skills, portfolio roles. We've got some GPs who work in diabetes, as I said myself. There was another colleague who works as a respiratory gypsy. We've had people work in rheumatology, A&E, etc., depending upon their roles. And we were able to attract people to these roles because of offering them portfolio careers. Previously in general practice, CPD time is usually taken in their own times. We managed to ensure that the GPs had considerable input into forming what the CPD would be and looking at their agenda, what they needed to improve on, and the trust facilitated those. And this was with designated leads with the wider trust. We've had people in various posts helping out with those.
So Mona's underselling herself there. Mona herself was divisional medical director for 3 years. So, you know, worked across the division in that senior medical role, reporting into the chief medical officer. I think one of the big advantages for the primary care services has been the risk appetite that comes as part of being a £750 million organisation. So there has been, to a certain extent, some level of financial underwriting in terms of being able to try things and not having to be as concerned about the profit margin, but also in terms of that wider support network that comes through the corporate teams. It makes it slightly safer to be able to take risks in a structured and well-governed way.
In addition, I was going to say, with regards to the risk appetite, in order to innovate, we just wanted to, the main thing for innovation is to be able to, given the time and the space and somebody to back you up to take that risk. And that's what the trust did for us, to look at what can we do differently. They gave us a thinking space and the time to say, this is, if you were to rewrite general practice, how would you rewrite it and how would you do things differently? And that's why when we very early joined, we said, look, actually, we want to do a home visiting team to be formed. It's not innovative, it's not new. I know several people have already done it, but I think we had the trust backing to ensure, and that gave us time to look at that. And then that helped us shape how we wanted to run the care in care homes and housebound patients and so forth. You were going to talk about ours roles. Sian, I'll leave that to you.
Okay. So I think, you know, the King's Fund published an extensive review of the R's roles. And I think one of the main challenges it pointed out has been that professional isolation, governance and resilience that primary care can provide when potentially it's not a service or a professional group they've got experience with. We haven't had those issues, so we haven't had any challenges in recruiting into first contact physios, additional pharmacy roles, or advanced nurse practitioners, because they link into all of our wider professional networks. Again, like the GPs, they then have those same opportunities for portfolio roles, CPD time, wider trust leadership, and rotational opportunities. So our R's roles, we feel, have been a huge benefit, and we've been able to really expand at quite a lot of pace there. one of the other benefits Mona alluded to earlier is that, again, primary care has not just had access to the standard corporate functions, but now is also supported by those elements that large organisations tend to have within, such as a QI function, and they've been really helpful on some of the innovations that we've wanted to set up. The Trust has a population health unit that's jointly in partnership with our local public health team, and our public health unit have done lots of analysis with us and with our primary care data in terms of understanding our population, understanding the impact of some of the initiatives that we've put in place. So really making sure we're taking an evidence data-based approach wherever possible to understand the benefits and disbenefits of things that we're doing. And then, of course, the Trust also has a research and development function within it, and is also the host for the Clinical Research Network for the West Midlands. And again, primary care is linking into that, and we're looking to make sure that primary care is participating in research as much as any acute service.
The R&D department have done really well with primary care. So the research opportunities for primary care have been really good. We've got one of our lead GPs in VI who's leading on this, and was a principal contributor for principal trial, which was nationally commended as well. The other thing that we wanted, when we looked at joining and forming VI, was the Trust's appetite for digital innovation. So Trust has always been known for being a very innovative provider of various services, and we wanted to link into this. And as a result of that, we've done quite a few things quite differently in some ways. We created a dashboard because of our combined data set from primary, secondary, and community care. And we can understand where our patients are at any given time, whether they're inpatients, how many attended A&E, and so forth, which has been really useful for us. And using, as I said, with QI opportunities and so forth, the data is the key for making sure that we understand where we are and where we are going, and be able to produce evidence-based results on our interventions. So we've been really, really lucky to be working with the Trust in terms of the digital innovation, leadership, and support that the Trust has provided as a combined organization. In addition, what we've got, as I've mentioned to you, we've got all the training and education. So leadership opportunities, we've had CD boot camps, which have been organized by departments, which are with other directorates. We have training opportunities for all the staff, not just the GPs, for the nurses, and also for the primary care admin staff as well. Very early on, we also realized that the problem in the whole healthcare system is not just primary care, it is actually how we work and the interface, and how the communication, which has come to light more and more so recently after COVID. Very early on, we looked at this and said we needed to intervene, and we need to understand how the communication flows between primary and secondary care. And we wanted to catch them early. So we wanted to be involved in FY1 education. So make sure that the discharge summaries were at a good standard, and ensure that the ask on primary care was understood. So we involved in that. And because various trusts have understood how the communication needs to improve, they have now asked us to be involved in training of various roles. So recently we've been doing it for the last 3 years, endoscopy nurse training, and just making sure that they understand how primary and secondary care work together better. So making my quality of referrals better and their discharge letters better. And that's the key that we have in most departments running through. So they run things through, and there's a change of pathway through with primary care to understand the impact. And that's possible because you're part of the same trust, and have those relationships and trust within each other to make things work in a better way.
So we wanted to just focus on one of the joint services that we've been delivering. So we were just going to give you a bit more information on our enhanced health in care home teams.
So just to say that when we started off, we had 17 care homes in the PCN, and this is just before the allocation of all the nursing homes to the PCNs. We have 4 nursing homes and 13 residential homes in our care homes, with about 500 residents. So what we did was we formed this enhanced health in care homes team, and this has got close links with nursing and pharmacy team as well. And they look through, when we've appointed people, they've had joint roles. So we've got pharmacy people who are working in pharmacy and also supporting the nursing home teams. And similarly, the people who work in the enhanced healthcare homes are also part of the community team as well. And they've got the support, the peer support of a wider team, and also the governance processes that go along with it. And what's been really beneficial is also the access to the care of the elderly consultant, which we personally find really, really helpful in terms of asking for advice around patient care and saving admissions and so forth. The out-of-hours care was picked up by the integrated nursing offer because this is care that is developed by the community team and that continues throughout rather than just during practice opening hours. We've had lots of digital and remote monitoring diagnostics which have supported this work. We have weekly MDT meetings, aim to have personalized care plans. Respect and ACP documents are done for all these people, all the patients, sorry. And we've got staff education. Residents vaccination program worked really well because of this team. And we also do performance tracking. So for example, a patient who comes in and is registered at a care home is not just about respect and personalized care plan. Any cough interaction that needs to be done with that patient is done. So for example, if it's a diabetes review or COPD review, it's done at that point. And medication reviews are supported by the elderly care consultant and by the pharmacy team. It shows the apps that we have over there, Lucy and Docabo apps and Techie Health. These are the various digital innovations that we've put in our nursing homes and care homes in order to improve patient care and support them via virtual monitoring. Prior to this intervention, as you can see, we had death in care homes of 54% and deaths in hospital for about 42%. And then following, this is data relating to 6 months period following the establishment of the team in 2021, we had 85% of the care home patients who died in the care home in their preferred place of death. Only 15% died in hospital, and that was majority. We looked at unavoidable admissions. 88% of the residents have already had a DNA CPR and respect in place, and that's numbers going up considerably as we speak, because we've got a dedicated team along with healthy aging coordinators working on those. 70% of the care homes residents who died had anticipatory drugs in place, and the 30% who did not actually need it because they were not symptomatic. And as a result of that, of the team being there, we've improved the COVID vaccination and flu vaccine uptake, and we've got reduced ambulance call-outs. And that's possible because the teams work very closely with the care staff in the care homes and nursing homes. And it's a bit of two-way support for each other and education for those staff.
Okay, so we've referenced a few times the work we've been doing on informatics and digital. So just to give you a few examples of what that looks like. So Mona's referenced the live data that we have. So through being integrated across primary care, community care, and the acute, we can track our patients in real time, look at risk stratification with a very rich data set. And we can also understand the things very live, so looking at who's going to A&E from our practices, what they're going with. We can also use this to then inform our end of life identification and our end of life care. Some of you may be aware that the Trust has done a partnership with Babylon. So this is looking at the digital offer to our registered patient population. So all of our patients remain registered with our 8 practices. Babylon is the digital tool through which they can access online self-care tools, but also book their virtual appointments with a range of clinicians. So we currently have advanced nurse practitioners, pharmacists, physiotherapists, and GPs available online. And we're looking to trial a mental health nurse through Babylon as well. So currently 12% of our practice population have registered through Babylon. Every single appointment can be rated and given a free text comment. So we get very live patient feedback around how they found the experience, as opposed to the one-off, annual survey or even the friends and family test. So we know that about 50% of our appointments are being rated, which is a better response rate than we had through the national survey. And on average, we're scoring 4.9 out of 5 on the quality of the appointment. So for us, that's been a real positive benefit. The patients being able to go online and book appointments is taking volume off the phone lines. But we have also done some work on improving our phone lines. So in this last year, we've gone to a cloud-based telephony system. Our 8 practices are organised into 2 groups of 4. We can obviously put our calls into multiple different queues. We can live monitor our call times, but we can also share our call volumes very tactically across each of the 4 groups, depending on where the longest wait is.
Just
Oh, sorry, go on, Mona.
So I'm just going to add on to the triage management. I was going to say that's really, really helpful for us in order to look at patients and RAG rate them and understand which patients are on the red pathway and select those patients to be sent for MDT meetings to be discussed in that pathway, or to the healthy aging coordinator. The daily A&E attendances, each practice, each clinician will get an email to say which patients are in. So you can just look at who's been in hospital, who's been has had an A&E attendance. And if there were recurrent A&E attendances with not reasons that you would think that patient needed to go to, we can refer them to social prescriber. The dashboard's really is helping us with our end of life register, improving those and making sure that 1% of the population are on the end of life register, and then accessing the care that they need so that we can have proactive care planning for those people. That's all I wanted to add to that. Thank you. Thanks, Sian.
Thanks. And then the final thing I was just going to add as well is that one of the other corporate services that we do have support from is our wider communications and engagement team. So our PCN website and our social media presence is supported by that corporate function. Not saying we've got it right yet, but again, that's helping us, particularly at the time with the things many of us would have seen in the media around the challenges in primary care in terms of managing our public message and making sure that we're being able to respond to things that we see out in the news and the media about people's experience of care locally. So we hope you get a sense really that there have been lots of benefits and lots of positives, huge amounts of innovation, but that's absolutely not to say we've done everything right. I think, as was said at the beginning, there wasn't a roadmap for this when we started. It has had to be figured out as we've gone along. So inevitably we've made mistakes, and there have been some things that hasn't gone as expected. So although there are huge benefits, we think, of centralizing those corporate functions, having them provided by the corporate services in terms of resilience and raising the bar, it does mean that they are potentially higher in cost and slower. You know, Mona and myself, for example, have sometimes had a conversation of, gosh, you know, would it not be possible and quicker to just go and buy something off Amazon, because sometimes our procurement systems aren't as fast as they could be. However, they are fully compliant. So, you know, some of that kind of tactical responsiveness that individual practices can have may have gone through that centralization process. The culture piece probably wasn't given as much focus as it should have been. There was a lot of focus on, you know, the innovation, on the services that we could do together, but thinking about the 2 cultures probably should have been a dedicated piece of work at the beginning. We're seeing the benefits now in terms of the soft power, as Mona alluded to, but particularly we didn't think about the relationships between practices as well as practices to the trust. This piece of work, as I said, started before primary care networks. So as each of our practices was onboarded into the vertical integration model, they didn't necessarily have a history of working together. And I think that's really important if you consider this model, to think about the relationships between any practices that want to come together. Primary care funding is a very different animal to acute funding and to community funding, and that has been a learning curve for our finance teams. While we think there's lots of positives to the model no longer being income driven, it does potentially mean that because profit is not a risk factor for some people, it does mean that they may be less concerned about some metrics that are that do generate money. So for example, QOF, and that's something that we've had to work on in terms of understanding the clinical benefit as opposed to the profit benefit. The complexity of the funding, particularly linked into the number of small pots that suddenly emerge for primary care and the short bid times, again, is just very different to how a large acute is used to operating. And so we are, you know, we're absolutely still working on that. This was referenced in the fuller stock take, but premises is an issue, both in terms of the quality and the age, but also the ownership arrangements. So across our 8 practices, we've got quite a variety of different ownership models. We've got some NHS PropCo, health centres owned by the Trust, current GP landlords and retired GP landlords, and trying to manage those conflicts of interest is particularly challenging. As Mona alluded to in one of our early slides around the journey, when this started, we did have a practice that was just over the border in Staffordshire. Wolverhampton is their closest acute trust, but it was felt that we would be able to overcome those barriers because this was where the patient flow came. Actually, that proved incredibly difficult. And then as PCNs formed and sat within CCG boundaries, it really drove that wedge further in. So we would say ideally all practices need to be in the same CCG area and in the same primary care network. Otherwise, potentially you're looking at different LESs and DESs across CCG areas. As more funding has come down the PCN network, you're potentially having to look in multiple different directions as well, back on that funding piece. And then while there are lots of benefits for the staff in terms of access to career progression opportunities, there being equity across agenda for change, CPD opportunities, rotational opportunities, it does mean that we do have to work within that framework for the non-medical staff. So we have had instances where other practices are offering higher base salaries that have attracted staff, and you do need to recognize that for some people it is the salary that is absolutely the key thing to them, and that's not a problem, and some of those softer benefits are less important to some. We think our softer benefits package will overcome that, but it's a risk you need to be aware of. So as we've said a few times, this is a piece of work that isn't over. This will continue to go on for some time, like any service development. But just to give you a sense of some of the things that we're working on now.
I think some of them are very operational, and you may find that they are quite, that other practices are doing nothing great in terms of innovation. But the main things that we're working on one is homelessness project. One of our practices is quite close to and looks after and has been actually spearheading the work in homeless population, especially when we had the Afghan population and also now the Ukrainian refugees and other homeless asylum seeker work as well, and has been led to all the changes in practices. All practices are safe surgeries and don't require patients' address details, etc., to register them and provide them with enhanced care. And that's been possible with working with the Trust Public Health and with the community services as well. We're looking at merging our GMS contracts because I think that's the natural progression of this partnership and makes life a lot easier, especially if we're going to do separate the urgent and planned care for primary care and deliver services at scale. Mental health offer, we've already said that we're going to get a mental health nurse in terms of via Babylon and others for a PCN, because we know, as everybody knows, mental health crisis in whole of primary and secondary care as a result of COVID and prior handling. We also are creating a central call handling in order to ensure that we can manage the demand. So this will be done via creating a central call hub, which will triage all the calls. And so where patients can put their information in, they'll put in via an app. But where they can't, the call handlers will be able to ensure that addresses the digital health inequalities and take their phone calls and put the right data so patients can then be triaged and given the right appointment and care navigation. Asylum seekers and refuge support, I've put that in homeless as well because it's quite similar in terms of what we've done with that. We've put joint LTC clinic. As I said, we've got some GPs who are gypsies with special interest in COPD, asthma, and it's ideal that we get our patients who are at higher need to be seen by those, and also with diabetes. We've also got rheumatology experts and so forth. So I think that just makes sure that the patients get the best level of care that we have. The digital access for excluded groups, as I said, with the apps that we have, the Lucy, Dockerbo, Techie Health, supporting care homes and the similar kind of apps we're thinking of using for our virtual wards for end-of-life care, which is also being formed at the moment. The remote diagnostics, again, with remote blood pressure monitoring, again, links in with the apps that I've mentioned over there. And one of the mundane stuff we've already mentioned about the lease management. So as we know that Sian's mentioned that we've had practices who are at different levels of ownership of their premises. We need to ensure that there is a robust process and a uniform process around how we manage those leases. So that's a big piece of work that we're doing at the moment for all our practices.
Okay, so just to summarise in on a few key messages, and then happy to take any questions. As we hope you've got the sense, we're not saying we are a finished product. This is a 5 to 10 year strategic change. We will continue to make mistakes, learn, improve things, and identify new areas that we want to add or change. The relationships between practices are just as important as the relationships with the trust. Potentially the primary care networks will now be starting to work on that in a different way to the experience that we had. But if you are looking to work with any primary care services, really do think about their pre-existing relationships, any pre-existing joint work, and any patient flows between them. There are no cost savings from primary care by doing this. And actually primary care is the bedrock to excellent NHS care. So really the Trust has decided to take positive financial risk in some areas by investing up front before we know that the funding will definitely come. So this is not about stripping away from primary care. This is about investing in primary care. You've probably noted through the presentation, there are some conflicts of interest, estates management, the GMS subcontracting approach. So that does need a carefully defined governance plan, management and support. And people need to be able to recognize that when they're in rooms, they may be wearing different hats depending on what the topic is that you're talking about. As we've said, we've tried to be honest. We didn't have a roadmap for doing this. We have made mistakes. Now we aren't a finished product and we will make more mistakes, I'm sure, as we go forward. And we aren't saying this is the answer for everybody. This has worked for us because of some of the history and the pre-existing relationships that Mona alluded to. So for us, this was right, but we aren't here making a sales pitch. We're here to just give you what we've done, share some lessons, and you may decide this is for you, or you may decide it's not, or you may want to steal certain bits from us. Anything is absolutely fine. There is no one size fits all.
Thank you, everyone. Happy to take questions. I know there's some in the chat.
Yeah, thank you. And thank you, Mona, for joining us on this conversation as well. Yeah, that was a fantastic presentation, really compelling. There are a few questions in the box, so we'll start from the beginning. And I will ask if those who have posted those questions, if you want to come on camera, you can ask the question yourself. It just makes it a little bit more conversational. So Jagtar, your question was first. If you're happy to talk through it, please come on camera now. If not, I'll obviously go through the question. So the question was around how inclusive is Babylon and can they cope with different language needs, and what's the usage by BAME communities?
Yep, so that's absolutely been one of our principal concerns. One of the benefits we've had is because of that access we have to the population public health unit, we've been able to work with them on the analysis. So 6 months in, we worked with them to do a statistical analysis of our usage of Babylon. So one of the things that we had to do in order to be GDPR compliant was to write out to all of our registered patients to describe what we were going to be doing with Babylon and to seek permission for data sharing. So people were given the opportunity to opt out of being part of the Babylon model. So in effect, we've got 3 population cohorts. We've got those who opted out of data sharing, those who have chosen to register with Babylon and use it, and those who we haven't yet heard from. So the public health unit did an analysis across a number of demographic and socioeconomic factors to look at whether that was driving out any kind of inequalities in uptake. So I can say that we have got uptake across kind of all age bands, all deprivation deciles, and all ethnicities. Where there is statistically significant difference, the biggest driver is age. So the over 75s and particularly the over 85s are the least likely to have registered and the most likely to have opted out of data sharing. There isn't actually very much difference between our British white population and our Asian population in terms of their uptake and engagement, but there is a statistically significant difference with our Black Afro-Caribbean population. That absolutely mirrors what we found with COVID vaccine uptake. So as a city, we know that's a piece of work we need to do more generally on engaging with that community on things like screening, immunisation. So not just Babylon, it is mirroring our experience. Probably the most interesting thing that we found was that deprivation doesn't appear to have been a driver of choice to use the app, and actually deciles 1 to 9, there isn't much difference in the likelihood of them having decided to use the app or not. And actually it's the most affluent in the city who are most likely to have opted out of the data sharing. So I think we've got a good understanding of who's using Babylon, who's not, who's opted out. But it's something that we need to continue to look at, something we're very cognizant of, and we don't want to create inequalities. But we haven't turned off any access routes. So people can still phone in, people can still use our website. So they remain. This is not a replacement, it's an addition.
Thank you. Mona, did you have something to say on that? Sorry, were you?
No, I think Sian's covered it perfectly, so I don't really need to add anything to that.
Really,
Thank you.
Yeah, it's really comprehensive. And also I was just impressed by the fact that you get quite high uptake of people who are rating the appointments, and presumably that's regularly monitored, and you can use that to adapt and change your services. And it's something that you don't always get. And I know I've worked with primary care in the past, and being able to get that up-to-date patient experience is really difficult, and it's difficult to share across organisations. So that's fantastic to hear that. So I'll move on to the next question. So Nicola Jones, I don't know whether you want to come on camera, or I'm happy again to talk through your question.
Oh, let me just see if I'm going to come on camera. Am I? I am. Hello.
I can hear you, Nicola. This is exciting.
Yeah,
Thank you.
I just wondered about an assessment of the total cost of this, because so I'm a GP. I would far from argue that primary care wouldn't need more investment. Of course it does, and I think that's a really good thing. But I think it's important we have an understanding of what happens here. I think one of the issues with the current system, as you flagged at the beginning, is moving resource from secondary care into primary care when you haven't got the strong links that you have got. I mean, it's really difficult. There's a lot of resistance to that. We've got new financial systems coming up, which are going to make it really difficult, even more difficult for a while until things settle down. So I do think with this kind of approach, understanding what you were spending before and understanding what you're spending now, and of course it's coming out of really different pots, isn't it? You know, practice accounts are a kind of mysterious area anyway, aren't they? And now it's, you know, in this kind of, you know, much more transparent domain. And I'm sure you've been thinking about all of that. Is there anything you can tell us about that which would help us to understand what's happened and what might happen if we were to follow this kind of model?
I think, like Sian's alluded to, that there are hidden costs which any organisation embarking on this would need to understand, and that's mainly about when you go into a trust, the levels of raising the bar of the HR processes, the recruitment processes, and so forth. It all has a cost element to that. So when you're trying to say, for example, all people need to be moved to agenda for change, there's going to be a cost element to that. But it's not just the cost element of that, it's just the how to act on that. So you need to have an HR department working on that. You need to have the finance department working on that and looking at that. And that's going to need a piece of investment. Once that's done, then there's ongoing HR support and back office function support and so forth. And that's something that we hadn't cottoned on to very early on. But I think very early on, when we had this initial conversation in 2015 with the trust, with our chief executive and the executive team, the main thing they were looking at, that we're looking at aligning incentives, and we're trying to align incentives providing the best patient care to ensure that patients are looked after where they need to be looked after. And if that meant investing more in primary care, the trust was totally behind that, to say, actually, if we invest and look at people early on, we would save that cost by admissions. And we did actually publish a paper in BJGP around that because of the model, we managed to reduce any attendances. This was prior to COVID as well. So I think that was the main thing that we wanted to do. We wanted to make sure the whole purpose of this vertical integration, as I said, we all quite well, practices were doing well. We weren't failing practices, weren't struggling to recruit or anything like that. What we wanted to do was to prove a concept that if we align incentives, can we make a difference? And obviously that comes at a cost initially. But I think in the long term, I think we needed that, because I know primary care has been underfunded and we needed the resource to be put in. People as partners working long hours and delivering the same, whereas actually having a more work-life balance, able to not do home visits and put that effort back into looking at your patients and looking at auditing and looking at the patients who need your care the most, giving yourself the flexibility of longer time for appointments with those people has, I think, I don't have any published data or evidence at the moment, but I'm sure we will be able to produce that. I think that's been a real benefit. And you can't underestimate when a clinician feels happy that they've done a good job and go back home, and patient feels cared for, how it can translate in a long term. These are very iterative stages and early stages to comment on that. But that's me as a working GP. That's my perception of what the change has done to me personally or to my colleagues at a grassroots levels. I hope that answers your question. I've just waffled away.
I'll just add a couple of bits there. I think there are some key things to think about. So as you say, the practice accounts can be a little bit of a dark art. So one of the big pieces of work that we have been doing is we started with a reconciliation process of how we moved money between practice accounts and the trust in order to make sure we were balancing budgets. We have been working with NHS EI and the CCG on the trust being able to be a direct recipient of the monies rather than it having to flow through multiple routes. So we've now managed to sort that for 6 of the 8 practices. So we do have a standard budget like you would expect of any large organisation service. So I look across 6 care groups as a Deputy Chief Operating Officer, a budget of about £110 million. Each of my 6 care groups has a designated budget. Very standard pay, non-pay. I have monthly performance meetings. We take the exact same approach with our primary care budget. One of the things that I alluded to is that while not being profit driven, we think is an advantage, you do have to recognise the risk it creates in that some of our sites, we did see a drop off in QOF in the first couple of years after they joined, which then meant a slight loss of income. So we've been doing lots of work to really focus on the clinical benefits to drive the QOF income back up. Some of the joint services we have done at risk, so there has been an overspend on the budget, but as a large organisation, and certainly within my division, I look at netting that off. So it's not necessary that each individual service has to fully be able to consume its own smoke. I can start to look at kind of higher levels of hierarchy in terms of making an overall budget balance across a number of my care groups rather than just within one, which is potentially an advantage.
That's really helpful. Thank you. Thanks both.
Thank you for that. Okay, so the next question is the Stout. If the Stout is on the line and wants to ask the question.
I am. Hi.
Hi.
Yeah, I'm David Stout. I'm working on health and care partnership in Milton Keynes at the moment. Yeah, I was interested. A really interesting presentation and really interesting work you're doing. You didn't say much, I don't think anyway, around how you're integrating with social care, because vertical integration isn't just about primary community and acute care. It is obviously care is very, very dependent on integration with social care. And I guess I could probably ask the same question about your links with mental health. So do you want to say a little bit about how your partnership currently is working in terms of those wider parts of integration and maybe where you're looking to go next with this in that space?
Oh, thank you. Thanks.
Yeah.
I'll start and then Sian, you can add on. So very early on when we formed the vertical integration, we went to adult and social care offices at the local, because we've got one council. And social prescribing is quite, you know, at the forefront at the moment with everyone. We started having social prescribers in our practices even before they were in the hours roles and so forth. So very early on, we started working with them. Our relationship with the local public health and with the council has been really, really great. And that shows in our local place-based partnership that's formed as well. So the PCNs as such, because it's moved on since the PCNs have been formed and the place boards and place-based collaborations are formed, that's totally different. But I think we recognize that very early on in working closely with social care and voluntary sectors. With that, I know that our primary care homes, working with fire officers and so forth, was quite useful. We're working with in various pathway interventions in terms of disease pathways, Alzheimer's Society and so forth. There are pieces of work that we're doing with them as well. Sian, did you want to have anything to add?
Yeah, so I think we have seen some soft tactical benefits that Mona's alluded to through the model, but in all honesty, I don't think as a vertically integrated model, we will have done anything different to the wider partnership working that's happening in the city. So I actually have a second role. I'm also the Director of Partnerships for Royal Wolverhampton, which is the name we've given to the place developments within the Black Country ICS. So our social care, VCS and mental health partners sit on that group, as do primary care. So we have really good working relationships through that place work, and that's something I'm personally responsible for. So again, I think our PCN has soft benefits through that, but I wouldn't say the vertical integration model explicitly gave us any benefits over and above the other PCNs have through being in that place work.
Are there any kind of negative consequences? Are you seen in some shape or form with suspicion because you've got sort of greater power or yeah? So.
Yeah, absolutely. And that was something that the trust was very cognizant of as practices were joining, that perhaps they'd get, you know, special deals and have a greater advantage. So wherever possible, we have tried to offer the same benefits to the other PCNs. So the GP MDT tool and the end of life data Mona referenced, although it started with our PCN, it's then been offered out across the whole of the city. So all practices could choose to sign on to the integrated data sharing, and our informatics team has worked with them to build their own versions of the dashboard wherever they want to sign up to that. Our care home model that we're providing as part of the DES was offered to all PCNs. Interestingly, the only part they wanted to pick up was the out of hours offer and the use of our remote monitoring and digital technology. Their in-hours offer, our other PCNs have kept themselves, but it is something we're very you know, aware of.
Thank you for asking that question. So the next question is from Rory. Rory, do you want to ask it?
Thank you again. Thanks, Mona, Sian. Just a really great model, and you describe it really well and really openly. And you just talk a little bit about you've had 8 or 10 practices now working with you for 8 years, so it must be a core part of the Wolverhampton story. And I'm just wondering why some of the other PCNs haven't been encouraged or haven't wanted to take up that offer, and some of the tensions and the sensibilities around that would be helpful to understand.
Yeah, so if I start and then I'll hand to Mona. So this has never been a model of acquisition. It's very much been looking for practices to come to us. So it has been a choice, so that's driven some of it. And as we said in our last slide, this model isn't for everyone. So we aren't just talking about, you know, other health and social care systems. We're recognising it isn't for all of the practices within Wolverhampton. So we have a couple of PCNs that have a very large footprint and are a super partnership with quite, you know, a developing model along the lines of Modality, who some of you may have heard of. So we aren't going out there making the sell. I think the PCN direction has kind of pulled groups together in a way that perhaps means now it wouldn't just be a decision for an individual practice, it would be a decision for a whole PCN. So that comes with larger decisions. So for us, we think we're probably fairly settled with our model now. Mona, I don't know whether there's anything you would add to that.
No, I think you've said it really. I think, as you said, Rory, the partnership model has got its own advantages, and this model has its own advantages. So it would appeal to some people who would be looking for more work-life balance, as was mentioned in some of the reviews and blogs. So if people, we know that in other areas who've got models like this running in Your Health Partnership in Birmingham, etc., there are people who are looking at end of career, and they want to leave their practice in safe hands, and they haven't been able to find a suitable partnership. They've been able to give their contracts over to an integrated trust, which has been helpful. But it's about where people are in their journey, and that and I think, as I said, it's just basically depending upon what appeals to people in terms of giving up their autonomy and working in a different way, in an innovative way, freeing them up. And some people just feel that this is not going to be a model for them, because they would like to be in charge of their own destiny, whereas others feel that they would like to work together with a bigger trust to shape innovation and shape patient care in a different way. And there's no right or wrong. So, as you said, we were the trust did not approach us. We approached the trust to form this vertical integration, and so have all the other practices who've been.
Thank you, really helpful.
Thank you. And Will, so do you want to come in and ask your question?
Yeah, thanks, Vic. Yeah, just to echo my thanks, firstly, Mona and Sian, for your presentation. I thought it was really informative, really interesting, really clear. So yeah, thank you. I think my question has kind of, to some extent, been answered by you, Mona, through a few of your answers. But there's obviously quite a big focus at the moment on the future of general practice. I work in the policy team at Confed, and we're kind of reading with interest lots of kind of big, lofty, visionary reports that are coming out about where primary care is headed and what the future of the partnership model is. So this is very interesting within that context, and I'm just interested in, to what extent, I mean, Mona, you've shared some of your experiences as a GP, but I'd be interested in hearing more about whether there's been any kind of more formal assessment of the GPs within your patch, and what they are saying about their well-being since the model has been introduced. Has it helped, for example, with burnout and work-related stress? We're in a situation, obviously, nationally, where we need to hold on to as many GPs as possible. So yeah, I'd be interested to know if it's helped in terms of retention, and if kind of GPs are doing fewer sessions per week, for example, and you talked about the benefits for work-life balance. Has that in turn led to staffing issues, with having to find other GPs to fill the gaps? Any more kind of detail around any of those questions would be really interesting to hear.
Yeah, so
I'll
shall I
start.
start? Oh.
You go ahead, Sian, please go ahead.
Okay, so the last NHS staff survey that came out, primary care as a group was either at the same score as our other care groups within the trust or just above it, and Wolverhampton as a trust tends to be in the top 20% in terms of staff survey scores. I haven't got any kind of data that I can reference you in terms of the GPs, but I suppose just a few things to give you as an example. All of the GPs who retired over the last year have returned to continue to work with us. We haven't had anybody leave. We recently created some deputy clinical director roles so that we could start to create succession planning for our medical leadership. And both of the applicants that we appointed to do that chose to do additional hours to take on the leadership responsibility rather than drop clinical hours. We have lots of touch points as a group where the teams can come together and talk. So I think there is a soft benefit of not being isolated. And when there are challenging experiences, the GPs or other primary care staff can come and talk to us. So for example, I think 2 weeks ago, we had a really challenging PPG. At one of our practices, patients getting, really irate, and the staff found it really difficult. But the next day they came into the management team, they were debriefed, talked about what went well, what we could do better next time. So I think there are benefits that our staff have. However, we aren't 100% recruited. I'm sure if I'd be happy for you to speak to, any of our GPs. I'm sure all of them would reflect a level of stress, but I think on balance they are experiencing benefit more than negative. That's my management line. I'll let Mona speak as an actual GP.
I think that's a very pertinent question. From my perspective, before, as working as a partner, doing long hours, we've all been job planned, so we've got patterns of work. We can give ourselves longer appointments for patients that we need to, and that, as I said, alleviates the stress because you feel you're doing a good job. There's CPD in hours which has been given to us. And we have several touch point meetings. We have every 2 weekly a GP catch-up meeting where people can just share their frustrations or whatever their issues are, and that are fed back. We have a monthly GP educational meeting, and that's carried on via throughout the pandemic as well. So we have different consultants working through and telling them that, we look at pathways, and sharing common good practice. And I think these are all that saves people not being alienated and isolated in their roles and are able to ask for help. We've got our, like I'm sure everybody has WhatsApp groups, and people can ask clinical questions or whatever, or training questions, or if they're, etc. So I think that's been really useful. But it's not just about GPs, it's also been about the nurses. So the nurses feel a lot of support. They've got their own touch points rather than just in the practice. They meetings with other nurses and peer support and so forth, which has been helpful. Same with the practice managers. They can, if somebody's struggling, they can ask for help from other practices. And obviously we won't say, like Sian said, that we're 100% recruited in that, because we know nobody, I shouldn't say nobody, but I'm sure that the challenges are experienced by other practices too. But generally, in terms of work-life balance and giving you space to innovate and think differently and think, okay, well, we're doing this, how can we make things better? What can we do differently in order to improve care for our patients? And sometimes when you bog down in a partnership model, looking at everything else for management and so forth, you don't have that space to innovate. And I think that's been the major benefit to us. But we'll continue to work on it, and we really, the whole team is really supportive of each other and of other colleagues to understand if somebody's being stressed out and well-being and so forth, how we can help and alleviate things or put things in place to help. So for example, we've got some people who struggle with typing and so forth. So we've just put down a model as such, so that we have digital dictation. So it's dictation software, so that frees up time, that makes things slightly better and quicker for patients, looking at referral pathways and across the patch, which like soft little things that we can do differently, save time on GP consultations and work through better. And I think everybody would appreciate that would help to a better working life condition.
Thanks both, really helpful.
Thank you. And can I just ask Mona, when you're talking about these meetings that happen, they're across all of the 8 practices with people together, are they, rather than just within the individual practice? Oh
no, definitely it's across the practices. It's all the GPs, and when we have clinical meetings, we invite all nurses, ANPs, physician associates, etc., whoever wants to be in there. And then we have a particular GP meeting. Nurses have their own nursing meetings, but it's across practices rather than, because some practices, we've got one practice which is got single-handed, so surely they can't have a meeting on their own.
Yeah, that's true. Thank you. Any more questions? So there's Hashim, you've got your hand up if you want to go next.
Yeah, cheers, Vic. Yeah, great presentation, Sian and Mona. I think both of you mentioned a few times public health. So I'm the sort of senior policy officer within the Confed on population health. I'd be interested to hear in terms of that developing and having that interaction with public health. Has that been so 2 points really? Has that been sort of kind of working more closely with the local authority, or have you kind of developed capacity and capability within the trust and primary care? And secondly, I think the point, Sian, you made about sort of relationships and culture. Again, it'd be interesting to hear how that shift from a sort of very acute and in primary care sort of reactive kind of approach to improving population health, has there sort of been, or have you been able to make sort of grounds around kind of taking a more kind of preventative upstream approach to sort of population health, obviously in terms of kind of to reduce the inequalities and improve outcomes?
Yep, so I'll start. So our public health population unit is jointly employed between the trust and the local authority. So they work with services across the whole organisation, so they aren't just for primary care, but I think in general they probably have tended to do a lot of their work with primary care and with community services. So within the unit we've got access to public health consultants, also statisticians. I don't know their technical job titles. So the piece of work I referenced around the Babylon analysis, although we commissioned it from the unit, we had a GP working with the team to make sure that we were appropriately understanding the data, constructing the extract, analysing the right things, and doing the interpretation in the right way. So naturally, some of our staff will have pre-existing preferences for how they want to work, and we want to support those so that individual has an interest in statistics and analysis. There are others whose interest has grown and we're trying to support them. So that's the colleague Mona referenced on research. So it's very much a joint piece of work. In terms of where that takes us on the prevention agenda. So again, the population health unit, because they are sponsored by the acute, get that same access to the integrated data across the whole system. So they have been able to do a level of analysis on our population needs that's quite extensive. So we do know where our particular issues are within the city. So for example, cardiovascular disease, drug and alcohol related issues. So I think we've got an extremely rich data set, and we're doing a number of pieces of work to turn that dial. But you will note that Wolverhampton is an outlier on kind of public health fingertips data on quite a few metrics in terms of life expectancy, infant mortality, drug and alcohol issues. So this is quite a citywide, systemic and endemic issue to a certain extent. So I don't think as a PCN it's something we'll be able to do alone, but hopefully the city benefits from the fact that that analysis and that approach is then shared with all and we can work together. I think there was a second part to your question and I can't remember what it is, but maybe Mona can.
I think you also mentioned about the population health and working through how this has been tangibly working differently. So as Sian mentioned, it's not just for just our PCN, but for other PCNs. So we've, as I said, we involved public health as a part of the vertically integrated team very early on. And the benefits of that, of the shared data set now are with looking at projects, looking at cervical screening in terms of prevention, and looking at why people don't attend for the cervical screening. If that data can be crunched into or analyzed into seeing whether it's any because of deprivation or certain areas, or whether it's ethnicity and some qualitative surveys around that. So we've got one of our foundation doctors, academic doctors working on that. And we've also looking at health inequalities in the whole of the city, where our pinch points are, and organizing NHS health checks in line with trust, PCNs and public health involved together. So I think that's what we, there are some tangible differences of working together, and how these relationships over time have improved. So I'm working with my other hat on, working on primary care backlog and looking at the impact of that. And again, impact of patients who've been on a waiting list and how many times they attend. Because of the integrated data set, we should be able to get that. We should be able to get some data from that to see how that influences how we proceed to restoration and recovery in primary care. I hope that answers your question.
Thank you. So we've got two questions. Well, Jagtar, and there's also another one from Nicola in the box. So I'll go to Nicola because that was first, and then Jagtar will come back to you afterwards. So the question from Nicola was, if GPs see fewer patients and have longer appointments in CPD time, all good for quality of care, does this mean that you need more GPs? In an area where it's difficult to help recruit, how might that help? And Nicola, you're very welcome to come on screen if there's anything else you want to add to that.
I think it's the longer appointments is, how do I say, it's it's a poison thing, isn't it? So you can do one, you think you've got a longer appointment, but then you think you're going to have an impact, but actually it works the other way around. So if actually having a longer appointment, actually sorting out the patient's real issues and signposting them to the teams that need to work, and that would, you can't say one appointment, one problem, and then the patient presents 3 times. So you actually spend 30 minutes, whereas you've got 15 minutes and you've done a good job for that. So I think that's where we invested in. And with COVID and everything turning to telephone triage, that has really turned everything on its head. So there are lots of things that you can do via the telephone. Not necessarily all telephone appointments are shorter. They can be equal or sometimes longer. But that helps. You can give the time. You can look at the time that we need to focus on the patients who really need your attention longer and deal with the others and signpost them, and care navigation has helped. So CPD time, I think GPs are already doing a lot of CPD in their own time. But as you said, we've taken the home visiting element of that away. So that's freed that time up as well. So there has been overall a net loss of GP time, I would agree with you. But I think not as much as we anticipated that we would. And giving longer appointments, it's not all appointments are longer. There are some longer appointments, there are some telephone appointments and so forth, which is, we tried this before COVID, and that's obviously after COVID, everybody's adopted, the longer appointments for some people who need face-to-face after a telephone triage and looking into that. But I think we started that just before COVID. We're looking at making sure that we give the longer appointments for patients who are most, who need them the most.
And the other thing I'd add is that, like with any other service that we look at, we're always challenging ourselves on what kind of profession and what level of role is needed to best undertake a particular intervention or service. So sometimes it's not always necessarily about replacing with a GP. So our GPs used to be the people who did joint injections, whereas now we're using physiotherapists. Mona's mentioned the home visiting service. So some of that loss isn't necessarily then needing to be filled by a GP, but that's not a different conversation in primary care. That's one I'd have with any of the services that I manage.
Thank you for answering that. And Jagtar, sorry, you've been patiently waiting there.
No.
Just to also say, your previous question in the box was answered first, so I hope you managed to listen to that.
I heard that. Yeah.
And I'm presuming you've got another one.
So, as you'd expect me, because my main passion is around inequalities, whether it be workforce or whether it be health for our community. And also it's about sharing good practice. So I could talk to Sian and Mona all day and quiz them to death until I've got all the tools that I need. I can steal and take back to my ICB, but we haven't got that time. So in summary, my question is, the work that you're doing, what inequalities have you shifted the dial on, and what initiatives have you put in place that you have hope that they will shift the dial on inequalities? Now, on supplementary to that, it's just a comment. The public and the community face many inequalities, and most of that is navigating the NHS system. And my own personal experience has been, my wife had a blood pressure of 200. And luckily I've got a GP friend who I play cricket with, rang him, he says, your wife's on the borderline of a stroke, take her into A&E. So that's what I did. I took her into A&E. They then told me, no, you shouldn't be here. You should have got, you got to go to the urgent care centre, which luckily was 50 yards away. Took her to urgent care centre. We sat there patiently for 3 hours. We got seen, we got medication, fantastic service. But during that same time, individuals were walking in and walking out and being seen. So I was curious of what was going on. And I am connected to the NHS. I should know better. So I spoke to the receptionist. She said, oh yeah, all these people have got a pre-booking. They dialed 111 and we see them within half an hour of them coming here. Move forward 4 weeks and my daughter's got a similar problem. We dial 111. And she lives in London, but she's at our house and she needs to get back with her kids. She's told by 111, we'll give you a call in 6 hours time from a GP. all these multiple messages are causing inequalities and not efficient. And if I can't navigate the system, how do we help the public who may be digitally poor, may not be communicated with? How can we stop them turning up to GP surgeries? Because that's what they're going to do. They're going to turn up to GP surgery and A&E if we can't get the 111 system right as well. So two questions within a question, but the latter one is more of a comment. So what top tips are you going to give me to take to my ICB from today to say I had a fantastic day with NHS Confed? Mona and Sian gave me these gifts. Now use them.
So I think turning the dial on inequalities is really difficult. And I think as a PCN, I would probably be overselling if I said as 8 practices, sorry, as one PCN of 6, we've turned the dial on probably what are citywide issues. What I think we have made the difference of is the understanding and the profile. Us going on that data integration journey first and convincing all of the other PCNs means that as a city, we have a very rich understanding of our issues and a high awareness of what we need to do, and we're working very closely with our local authorities. So again, coming back to the Babylon and COVID vaccination example, the Black Afro-Caribbean population, we've got real understanding of the aspects of healthcare they're not engaging with. We've got some quantitative and qualitative data around why not, and so we're now trying to work with community leaders, things like being in barbershops and hair salons, around how we turn that dial. I wouldn't say I could point you to a public health outcome that says we've made a difference. So I think it's understanding. I think it's the rigorousness and the validity of the data on which that understanding is based, and we're doing work now, but I don't think I could say it's turned the dial. The one thing that I think as a PCN we have been able to do quite quickly and extensively is we decided to take the lead as a city on the asylum seeker and refugee support. So Wolverhampton was designated as a welcoming city. So we are one of only a couple of places in the country that received women and family asylum seekers. So we've had over 400 people come through that facility now, and they are all registered with our practices. About 50% of that cohort are children. So in terms of working with them to make sure they are appropriately registered, have access to translation services, have appointments, has been a huge piece of work. We also were a receiving city for Afghan refugees as well. And again, we took the lead on that. So that some of that kind of risk appetite and that underwriting that comes through being part of the trust enabled us to do that in a way that perhaps some of the other PCNs couldn't. And that's been a really important piece of work with a particularly at-risk community. Mona, is there anything else you'd add on inequalities?
Sure, I think inequalities is quite topical, and I think as and always has been, but just become to forefront with COVID. And if I say we've got a really good roadmap for you to give to you to follow, I'd be lying. I think we've done things by raising awareness of health inequalities, using our public health to understand where the patches are, where there's increased health inequalities. And we looked at that during our COVID vaccinations and made sure that we were looking and providing that in those areas closer to home by different opportunities. We worked with people who are homeless in homeless shelters. We worked in places of faith and working now with public health in order to deliver our NHS health checks and information leaflets for various diseases and so forth, make sure they are in all languages that are currently in our city. And also we're looking at working with, there's been in fuller stock take, and also from the digital innovation in order of getting the appointments. So the central hub that we have, we would try to ensure that we can the problem that you mentioned, that people working with NHS 111 are accessing primary care and having a variation of a response and reducing those inequalities. So people who can put their information in on online triage, but we look at our nurse training and our receptions training to ensure that they can get the data from the patients who can't type in and would just prefer a phone call, so that they put it in the same way. So when we form our triaged hub, they'll all be put in the same and based on need, care navigated and assessed. So I think those are some of the things that we're working on with that, and digital inequalities, and working with public health, getting some devices into people who don't have those devices, but inequalities, or need some education around that. Education is the wrong word to use, but in order to support them to learn how to use those devices and put things in place. I think those are the kind of things that we're working on. I know that's very, how do I say, more the doing than the strategic overview, but I hope that helps you in some ways.
It really helps. It really helps, but my key point always is it's a simple binary definition, avoidable and preventable, but the solutions are so complex that we can talk about inequalities, but we can rarely talk about the dial that we moved because of it. And this has been the problem in boardrooms in the NHS. We love the definition, we love that we're working on it, but very rarely, when you ask a leader, what inequality did you change and move? What outcome did you achieve? They're unable to tell you. Because I mean, I sit on lots of boards, panels for interviews. It's the favorite question. And I am absolutely amazed that people applying for chief exec roles, directors of medicine or nursing are unable to answer that question. My background is fire service. I can tell you exactly what inequalities we changed. We reduced deaths in the West Midlands from 40 a year to less than 10 a year. In the country, from 800 a year to less than 200. That was an inequality. And we knew where the inequalities were because we've used, in my time, because I'm that old, drawing pins in a map to say, this is where the deaths are occurring. Right, get out there and get your smoke detectors out. And you mentioned it, Mona, our lessons for the NHS have come sharp under COVID. We should have known where the deaths were going to occur. They're the same places where fire deaths occur, where the crime occurs, where the unemployment rates are.
Thank you for that, Jagtar. So we'll end on that comment because we've run 5 minutes over time. I apologise about that. And I just want to say thank you very much to Sian and to Mona for a really fascinating presentation and covering a huge range of questions from people. And I'm really pleased and thank you to everybody who actually came on screen and had that discussion. It just made it a little bit more vibrant. If anybody has any questions that we want to follow up, you could always just quickly put them in the chat box or email me, which I'll put my email address in the chat box and we can take those up offline. But I will pause here and say thank you to everybody, and we will share a copy of the slides post-event.
Thank you so much.
Thank you.